Without further ado, I would like to invite Professor Cornelia Landersdorfer from Monash University to talk on in vitro infection models. Oops. Please, Cornelia.
Yes, thank you very much for the opportunity to present some of our recent data. And why do in vitro infection models? Well, they allow us to evaluate a range of regimens and inform the selection of those which are most likely to be successful in patients, both for the clinical trials during drug development and the routine use of the antibiotic. And by combining well-designed preclinical studies with cutting-edge data analysis, we can actually optimize antibiotic dosing regimens for individual patients and also the bacterial characteristics. So we can maximize bacterial killing, suppress resistance emergence, and ultimately translate those optimized regimens to the clinic. In terms of in vitro models, one very common and powerful one is the so-called hollow fiber infection model. And this allows us to mimic the pharmacokinetic profiles that are seen in patients and expose the bacteria to these PK profiles. We can also account for the patient characteristics that affect the PK at the target site and for bacterial characteristics. And during these studies, we can measure the total bacterial counts as well as resistant bacteria, and we can perform various omics analysis, which can then inform our mathematical modeling. We are using a similar model for biofilm bacteria, which is the CDC dynamic biofilm reactor. So I've got the first example, which is about meropenem and tobramycin combination against hypermutable multi-drug-resistant Pseudomonas aeruginosa from patients with cystic fibrosis. And in this particular study, we had 2 bacterial isolates and 9 treatments with antibiotic. As mentioned in this model, we simulated the expected epithelial lining fluid concentrations over time that would be observed in the patients and exposed the bacteria to this. And we performed transcriptomic and genomic analysis. So here is a small subset of the data. We can see the log 10 colony forming units per mil on the y-axis over time. And we can see the symbols, which are the observed data. In black, we've got a growth control. In purple, we've got meropenem monotherapy given every 8 hours. And in red, tobramycin. And we can see both of these monotherapies provided initial bacterial killing, but followed by rapid regrowth and resistance emergence. However, when we combine both in the blue symbols, then we can see initially synergy. So it works much better in the combination. But then over time, the synergy is lost because of adaptive resistance developing against tobramycin. And these underlying processes can be elucidated by doing the transcriptomics and genomics, and these results inform our mechanism-based mathematical model, which are the lines through the data. But really, an important point of developing such a model is that we can use it to predict what's happening with other dosing regimens. So for example, in the middle panel, we use the model to predict what would happen if we dose the meropenem in the combination as a continuous infusion, 6 grams per day, and combine it with the tobramycin. And that's the orange curve in the graph, which was predicted to achieve bacterial killing without the bacteria growing back and becoming resistant. And actually, when studying that regimen in the experimental hollow fiber model, it also performed very well, as we can see in the orange symbols there. So from this example, this shows promise to be able to use this approach to optimize antibiotic exposure profiles, and we can translate this to patients by integrating with population pharmacokinetics. And for individual patients, by doing TDM and maybe adaptive feedback control as well. So, and then our second example, we looked at the effect of different meropenem resistance mutations on the bacterial response. And for this, we looked at the main resistance mechanisms against meropenem, which is loss of antiporins, increased efflux, and increased beta-lactamases. So we had 7 isogenic strains of the bacterium Pseudomonas aeruginosa that represent these main resistance mechanisms. Both the wild type, the single mutant bacteria, and the double mutations. And here is a subset of the data which shows the 3 strains which all had the same MIC of 4 milligrams per liter to meropenem, but different resistance mechanisms. And here we could see that with 2 of the strains, if they are exposed to a dose of 6 grams per day meropenem, there is regrowth of the bacteria with resistance. But the 3rd strain didn't show any regrowth or resistance despite having the same MIC. So the MIC couldn't explain this response. But fortunately, a quantitative and systems pharmacology mathematical model could explain all of this data, as we can see by the fits, which are the lines. And this model basically could describe the responses of all of the 7 strains, different treatment regimens, 90 profiles in total. And just briefly, the way this model can predict it is by including the effect of those different resistance mutations on the meropenem concentration at the target site in the bacterium. Now, this was using generated lab strains with resistance mutations, but we were also very recently able to translate this approach to clinical isolates from patients belonging to a worldwide high-risk clone of Pseudomonas aeruginosa. So overall, this shows promise for using this in vitro modeling and mathematical modeling approach to optimize regimens, not only for patient, but also for bacterial characteristics, such as different resistance mutations. And lastly, we looked at ceftolozane tazobactam treatment of a clinical hypermutable Pseudomonas isolate and simulating the PK in lung fluid. So here we can see again the total bacterial population. In black we've got the growth control, and in orange and blue are the 4.5 grams per day and 9 grams per day treatment with ceftolozane tazobactam, where both of these treatments achieved some bacterial killing, but it resulted in resistance emergence, as we can see in the bottom panel, where resistance emerged higher than in the control. Now we looked at the extracellular metabolites in this system. And there were some metabolites, such as ornithine, that increased when bacterial concentrations increased, with total bacterial concentration. And also some other metabolites, such as ribose 5-phosphate, they correlated with the resistant bacterial population, and we could mathematically model that as well. So this, we believe, also shows some promise to use such an approach to maybe identify potential bacterial biomarkers in the future to monitor resistance emergence. Thank you very much.